Now, our next topic is leukemias or blood cancers, leukemia, lymphoma, and different type of blood cancers. Before we discuss in detail the different types of blood cancers and their diagnosis, let's discuss or do a brief review of formation of different type of blood cells, where they are formed and how they are formed. So in bone marrow, the bone marrow of adults, they contain hematopoietic stem cells. Hematopoietic stem cells, what are hematopoietic stem cells? They are pluripotent. Pluripotent means they can differentiate into any type of cells. So these pluripotent stem cells, or you can say stem cells simply. So stem cells differentiate into two types of cells, that is myeloblasts, and the second one is lymphoblasts. Now myeloblasts, they are they differentiate into erythrocytes, thrombocyte, and leukocytes. Red blood cells, thrombocyte differentiate into megakaryocytes and platelet, and leukocytes such as neutrophils, eosinophils, and basophils, and monocytes. So all of these cells, they arise from myeloblast cells. While lymphoblast cells, they result in the formation of B lymphocytes and T lymphocytes. So there is a separate precursor cell for lymphocytes such as B lymphocytes and T lymphocytes. And all the remaining cells, the cells that are present in the blood, such as red blood cells, platelets, and the remaining white blood cells such as monocytes and granulocytes such as neutrophils, basophils, and eosinophils. They have a common precursor cell that is known as myeloblasts. Now, when these cells are formed in the bone marrow, erythrocytes, thrombocytes, leukocytes, B lymphocyte, and T lymphocytes, they all travel to different organs in the body. In the blood, they are released in the circulation, peripheral circulation, and then they settle down in different areas in the body, such as white blood cells, lymphocytes, and B lymphocytes and T lymphocytes. They settle down in the lymph nodes, in the spleen, in the thymus. T lymphocytes settle down in the thymus. So there are different organs in the body where they settle down. So that's why when a leukemia or a blood cancer occur, there is associated lymphadenopathy and splenomegaly and hepatomegaly and thymus gland enlargement. So that's why in different type of cancers, hepatosplenomegaly and lymph node enlargement, it can occur. So this was a brief description of blood cells formation. Now let's discuss a different type of leukemias.
Sir, can you please enlarge the image a little bit so that very small font?
Just give me a minute. Is it all right now?
Thank you.
So leukemia, it can be acute or it can be chronic. Leukemia can be myeloid leukemia, it can be lymphoid leukemia. So we are going to we are going to discuss some general points which can tell you about if it's an acute leukemia or if it's an chronic leukemia, and if it's a lymphoid leukemia or it's a myeloid leukemia. So remember that we discussed that myeloid leukemia will be, they will contain uh, either leukocytes such as neutrophils, eosinophils, and basophils, or platelets or erythrocytes, increased proliferation of all these cells in myeloid leukemias. And in lymphoid leukemias, only lymphocytes will proliferate. So remember this difference. So how now, what are the general points on the basis of which we can decide if it's an acute leukemia or a chronic leukemia, and if it's a myeloid leukemia or a lymphoid leukemia? So first of all, look at the age. If age is less than 40 years, if the patient is young or a child, then it will be acute leukemia. Because acute lymphoblastic leukemia and acute myeloid leukemia, they are common in young people or children. The second thing is to decide if it's a myeloid leukemia or if it's a lymphoid leukemia. So if there is a lymphadenopathy, it is most likely to be lymphoid leukemia, because we discussed that after formation in the bone marrow, this lymphoid cells such as lymphocytes and B lymphocytes and T lymphocytes, they will travel to the lymph nodes, spleen, and thymus, etc. So if lymphadenopathy is present, then it is most likely a lymphoid leukemia.
Sir,
So these, yes,
lymphadenopathy can be present in the other one, myeloid also,
yes, it can be present in the
both
myeloid
of them.
leukemia as well. But but yes, it is present in both of them,
Uh-huh.
but it is more common in lymphoid leukemia.
Lymphoid. Lymphoid. Okay.
And in the Plab1 exam, they usually ask you about the common things. So that's why for Plab1 exam, you can remember this point that if lymphadenopathy is present, then it's definitely a lymphoid leukemia. And there will be some other hints given as well.
Okay.
But if other hints are not given and they have just given you lymphadenopathy and they ask you about the most likely diagnosis, so the most likely diagnosis will be a lymphoid leukemia, because lymphadenopathy is more common in lymphoid leukemia. Now, the first acute leukemia is acute lymphoid leukemia, ALL. So what happens in ALL? ALL is basically acute lymphoid leukemia, or it is also known as acute lymphoblastic leukemia. So what happens in acute lymphoblastic leukemia? That there is excessive proliferation of these lymphoblasts. These blast cells, these lymphoblasts, they are present in the bone marrow. So there will be excessive proliferation of these lymphoblasts. So when these lymphoblasts, they excessively proliferate, what will happen in the bone marrow? It will compress the other cell lines. It will compress the, because if they excessively grow, they will utilize or consume all the nutrition. So these myeloblast cells, they will stop growing, or they will be suppressed. So RBC will be reduced, a person will develop anemia, platelets will be reduced, he will develop thrombocytopenia, and leukocytes will be reduced and he will develop neutropenia. So this is the basic mechanism of acute lymphoblastic leukemia, that there is excessive proliferation of lymphoblastic cells, which lead to compression or suppression of the other cell lines. So most of the cases of acute lymphoid leukemia, they are um, idiopathic. There is no apparent cause, but radiation exposure, chemotherapeutic agents, and some retroviruses, they can cause lymphoid leukemia. And the common presentation of acute lymphoblastic leukemia or ALL is the features of anemia, thrombocytopenia, and neutropenia. All of them will be present. So the feature of anemia will present as tiredness and lethargy and pallor. The features of thrombocytopenia, they include, we have discussed that whenever there's a platelet disorder, the patient will present to us with skin and mucosal bleed. So bleeding from the gums, petechiae, purpura, or ecchymosis, it is a manifestation of thrombocytopenia. And neutropenia will manifest as recurrent and severe infections, commonly in the oral, throat, skin, or perianal region. The person will have a history of recurrent severe infections. Opportunistic organisms such as herpes zoster, CMV, measles, candidiasis, pneumocystis, all of these infections are common in patients with acute lymphoblastic leukemia due to neutropenia. So the problem was at the lymphoblastic level. Excessive proliferation of lymphoblasts led to deficiency of all other cell lines, which will present to you with the many features of these things. These lymphoblasts that are excessively proliferating in the bone marrow, they will travel to the lymph nodes, so there will be lymphadenopathy. They will travel to spleen and liver, so there will be hepatosplenomegaly or cardiomegaly, and sometimes there's CNS involvement as well in acute lymphoblastic leukemia. So this was about the presentation of ALL. Now remember that ALL is common in children. There are two types of acute leukemia. One is ALL and one is AML. ALL is common in children and AML is common in adults. So up to 15 years of age, if someone present to you with features of pancytopenia or a suspected malignancy, then it will be most likely lymphoblastic leukemia or ALL. And in adults above 50, 20, 25, then it will be AML. The cause of ALL and AML, both of them, is a mutation in the precursor blood cells, which lead to either lymphoblastic leukemia or myeloblastic leukemia. That is the proliferation of precursor cells of these white blood cells. So how the diagnosis is made? The initial investigation will be full blood count, and full blood count will show pancytopenia, that is anemia, neutropenia, and thrombocytopenia. White cell count can be low, it can be normal, or sometime elevated as well.
Sorry, can I just ask one question?
Yes.
I just wanted to ask, like, this ALL and AML, are they both the same, but the name is different in children and adults?
They are not the same. Uh, Let
Because
me
it's
show you the diagram again. In AML, there will be the excessive proliferation of myeloblastic cells.
right,
And in ALL, there will be lymphoblastic cells proliferation. The peripheral smear in case of lymphoblastic leukemia, it will show lymphocytes or lymphoblasts.
right,
And the peripheral smear in and the bone marrow, in this case, will show myeloblasts. There's a slight difference, histological difference between myeloblast and lymphoblasts. One difference is that the myeloblasts, they differentiate into RBC, thrombocyte, and leukocytes. That is neutrophil, eosinophils, and basophils. So if you in on a peripheral blood film, you see all stages of neutrophils, basophils, and eosinophils, then it will be a myeloblastic leukemia, either acute or chronic. And if you see lymphocytes, then it will be a lymphoblastic leukemia. So they are not
yes,
same, they are different.
okay,
ALL is common in children and AML is common in adults. But the presentation of both of them is same, if that's what you are trying to ask. Both of them can present as pancytopenia.
yes,
So pancytopenia and myeloblasts on bone marrow, then it will be AML. Pancytopenia and lymphoblasts on bone marrow, then it will be ALL.
right. It's clear now.
So because these lymphoblastic cells, they can infiltrate the lymph nodes, liver and spleen, so there can be lymphadenopathy and hepatosplenomegaly. So the diagnosis is made, the initial investigation is include full blood count, and it will show pancytopenia. Remember that many other disorders can cause pancytopenia. The most important one that you need to remember for Plab1 is aplastic anemia. Aplastic anemia can also presents with the feature of pancytopenia. Aplastic anemia, in aplastic anemia, there is bone marrow failure, so no cell lines are formed due to autoimmune destruction of these cells. There is no formation of RBCs, WBCs, and platelets. So aplastic anemia is an important differential diagnosis that you need to remember for type 1.